Live on, doctor.
Okay. Very good evening to all of you. Welcome to this wonderful Spotlight on Myopia Management webinar. It is a focused webinar to talk about a problem which is beginning to sweep the world thanks to our own practices, and we are trying to give a good vision without getting amblyopia in the children. So at the outset, I'd like to introduce two people before I hand over to them. My slide is visible?
Yeah, yes, sir.
Yes.
Okay. So we have our president of Tamil Nadu Ophthalmic Association, Dr. Sujata Mohan. So who has been, at the programs either on site or offline, online for the past 3 months. We have done so many programs in different specialties, including international programs. She is the executive medical director of Rajan Eye Care Hospital in Chennai and a phaco-refractive corneal surgeon. She is also the president of Madras City Ophthalmic Association, and she is a proud recipient of Nari Shakti Puraskar Award. So welcome, madam. And next, I would like to introduce Dr. Kalpana Narendran, who heads the pediatric and IOL services at Aravind Eye Hospital, Coimbatore. Dr. Kalpana madam has been with pediatric ophthalmology and practicing for the last 3 decades. So ever since she finished her master post graduation, so she has been doing a lot of pediatric services and has gone all over the world giving talks on pediatric services. Over to you, madam, Dr. Kalpana madam.
Thank you. Thank you, sir, for the nice introduction. And good evening, everyone. And hello, nice to see you. After a long time, I'm in a webinar. I always try to say no. But anyway, it's really nice to see all of you. And so today's webinar will be on Spotlight on Myopia Management, mainly because this is a National Myopia Week, mainly to create awareness in the community. As we all know that this is becoming a most pressing issue in vision care in children. So it's very important to discuss about the newer trends in the management of myopia. And this is being hosted from Aravind Hospital, Coimbatore, under the aegis of Tamil Nadu Ophthalmic Association. Thanks to Dr. Sujata ma'am, the president of TNOA, for accepting and allowing us to host this meeting. So globally, we all know that myopia is on the rise and it's affecting young children and adults. And the projections indicate at least 50% of the population will be myopic in 2020 by 2050. So this rapid increase will cause a lot of public health challenges because of the complications myopia can be associated with, especially the pathological myopia like glaucoma, cataract, and retinal detachment, and so on. So there's a lot of newer trends in the management of myopia. Like if you say like 10 years ago, it was only spectacles. But then now we have a lot of other options like different types of spectacles or control glasses, what we call. And then you have the orthokeratology or the contact lens for myopia control, and then the atropine usage. So we have excellent speakers today, a lot of experience in myopia management. So they will be enlightening us on the different management strategies for the treatment of myopia. And we're looking forward to hearing them. And thank you again. Thank you, madam. And over to you, Dr. Sujata ma'am, for a few words.
Yeah, thank you. Good evening, everyone. On behalf of TNOA, it gives me great pleasure to welcome you all for the Spotlight on Myopia Management. At the outset, my sincere thanks to Dr. Kalpana, Dr. Sandra, and Dr. DC for involving TNOA in this webinar. In the past decade, our understanding of myopia pathogenesis and the tools for its control have advanced exponentially. We moved beyond a simple correction to true management. Over the next hour, we will hear from leading experts who are at the forefront of this transformation. We will hear the experts discuss the comparative efficacy of pharmacological interventions such as low-dose atropine, explore advanced optical solutions, including specialized spectacle lenses and contact lenses, and refine our clinical communication strategies with patients and parents. Our goal is simple but ambitious: to learn to standardize a comprehensive, practical, and proactive approach to myopia management that can be implemented at all levels, ensuring every child at risk receives the most effective care available. Welcome you all once again for the Myopia Spotlight. And I'd like to thank all the speakers and the faculty for taking your time off and spending 1 hour this evening. Thank you. Looking forward to a wonderful session.
Thank you, ma'am. And I think over to you, Sandra.
Yes.
Thank you very much. And it's my pleasure to again invite you all to this webinar on myopia management. And it's my pleasure to also introduce the panelists for today. Dr. R. Meenakshi, Chief Medical Officer, Head of the Pediatric Services, Aravind Eye Hospital, Tirunelveli, and she has been very supportive in all our meetings. And thank you so much for connecting today, ma'am. Dr. V. Madhavan, sir, Vice President of TNOA and State Vice President, West Zone IMA from Abhirami Eye Hospital, Erode. And thank you very much for accepting, sir. Dr. Kalaivani, Kavita Kalaivani, who is the Deputy Director from the Department of Pediatric Ophthalmology, Shankar Nethralaya, Chennai. And she's been actively involved. We have a close association for many years now. And she's been very active in teaching postgraduates, fellows, optomes, and takes care of pediatric neurophthal, our interest in complex strabismus, rheumatic cataract, Botox, and adult cataract surgeries. And our close association with Dr. Janani R from Aravind Eye Hospital, Salem, consultant pediatric ophthalmologist, having numerous publications. And she has innovated a very nice spin surgery model, which is very useful for the postgraduates. And thank you all for joining me to introduce the first speaker for this session, Dr. Jitendra Jetani, who is very active in pediatric ophthalmology in general and myopia also, Director of Baroda Children's Eye Care and Squint Clinic, our alumni from Aravind Eye Hospital, Madurai, way back in 2004 to 6. He did a F&B from there, and he has a huge number of publications, numerous presentations, and many, many awards. And over to you, Dr. Jitendra, for the first talk of today, and he'll be presenting on the diagnostics of myopia.
Yeah. Should I share the screen?
Yes.
Yeah. So thank you so much, Sandra, for the invite and for a wonderful introduction. Respected teachers, Kalpana Madam has always been a teacher and an inspiration for all of us who have, worked with her or, worked in pediatric ophthalm. And thank you to TNOA for making me part of this webinar. Now, this is a talk basically on myopia diagnostics, and I would be taking you through what we are currently doing and what we may see in coming years, like in near future and maybe in far future or as the time goes on. So right now, at least whatever we have understood or whatever we have done or whatever we have researched, the key components of progression. So basically, to begin with, I would just say that we are into myopia to tackle or handle myopia progression. So we will be basically talking about myopia progression as a disease, not really myopia, because myopia is being treated since years altogether. We are talking about myopia progression and stopping the growth of myopia progression, mainly because if you see that each diopter matters, and I've just given a slide from Review of Myopia Management, which talks about how each 2 diopter growth can multiply the risk of other diseases like myopic maculopathy, retinal detachment, and other diseases. So right now we understand that refraction, axial length, keratometry or keratometry upon corneal radius ratio, and nowadays choroidal thickness is gradually coming up, being the key component for myopia progression. Now, this is something which we do in our clinic, and I'm sure that most of the clinics have their own way of documenting it. And so right now, what is progression? A progression of myopia is supposed to be any progression over a period of year if there is a progression of more than 0.5 diopter, or if there is an axial elongation of more than 0.2 or 0.3 millimeter. That is known as myopia progression, and anything below that is considered either physiological or not really treatable. So what are the measurable factors? At this point of time, I already discussed that. Something recently published by Dr. Shruti and Dr. Shruti has published an article recently in AJO where they have talked about inflammatory markers. There was a previous publication from Dr. Jyoti Matalia from NN on tear film dopamine. So yes, biomarkers are also becoming more and more important. There is a small photograph to show that now choroidal thickness is gradually coming up and becoming a more important factor, which can be altered, or which may be a precursor, or which may tell us beforehand that this particular patient may progress. And it is basically the choroid which starts thinning out, and it starts giving way to the retina to progress. So I think there will be more work on what is normative choroidal thickness and how it is progressing. So at this point of time, what are all the things? We have optical biometers. So that is what we use to measure axial length, keratometry. Attachments like Cloud Clip. This is an attachment which is used basically to find out how much amount of near work the child is doing and whether he is sitting indoors or how much outdoor timing he has. It has an inbuilt software, so you can actually calculate how many hours he is sitting and what are the risk factors. And it also gives you a predictive index and a chart which is for the patient. So there are two interfaces, one for the patient and one for the doctor. I think what will happen gradually is that frames like Meta and all those frames gradually may develop this ability in itself, because basically you need a couple of sensors which can measure this. And we were talking with the Meta guys mainly to how we can do this, the function of Cloud Clip, which can be incorporated into this. Peripheral refraction, as you can see, I have put up a photograph of a peripheral autorefractor, and this is our innovation on peripheral refraction. So peripheral refraction has come up mainly because of the fact that peripheral refraction theory is one of the most accepted theory at this point of time for myopia progression. And most of the myopia frames which are currently available work on peripheral hyperopia, and they try to make that refraction more and more myopic. Now that is regarding the treatment part. So this is, I'm just trying to show that you can have a retinoscope and a handle on the retinoscope, and this handle can gradually, so it has two LEDs on the either side, and the patient will fix peripherally on it, and you can do the refraction to find out whether patient has peripheral hyperopia or not. Next is AL upon CR ratio. There's a very good article on the normative data of AL upon CR ratio by Dr. Sandra and from Aravind Eye Hospital, Coimbatore. But we can use this AL upon CR ratio as predicted by another article in Asia Pacific Journal, where they have tried to suggest that any AL upon CR ratio which is more than 3 or 3.2 may also progress. So not only AL upon CR ratio is a good ratio to talk about the variance of myopia in the population, but also for the fact that it may be used as a predictor whether this particular patient will progress or not. Similarly, for choroidal thickness also, just like axial length, they have suggested that choroidal thickness is actually a precursor to the axial growth, and one can also use it as a prognostic factor when using atropine or when using myopia control glasses. If the choroidal thickness starts picking up, there is a good chance that myopia would not progress further. Now, for predicting these particular things, whether this particular patient will progress or not, there are multiple calculators which I will be showing in the next slide. But first, we will look into what optical biometers and how optical biometers have now evolved from being used for cataract to being used for myopia. So already there is an optical biometer for myopia management, which gives you all these readings, which includes AL upon CR ratio, central corneal thickness, spherical power. So it is basically an optical biometer which has an incorporated autorefractor, and it gives you 12 parameters which help you in knowing whether this particular patient will progress. And also it gives you a graphical map over a period of time. Now, right now, Myopia Master is there, OPM 12 is there, Maya is there from Topcon, and Hewitt's also has its own optical biometer which can assist you for myopia management. So all these things, what they do is they bring at one particular point, you can do multiple tests and you don't have to shift the patient from place to place. At the same time, it also gives you an objective graph which can be used to tell the patient that your myopia is progressing, so you can discuss with the patient. Now this is the calculator, BHPI calculator, which is incorporated with Myopia Master from Oculus. Now I will just show you how how you can use this calculator. This is basically a screen recording. This is available free. It is free online, bhvi.org. You can go on that website. You can there will be a window like this. There is a drop down menu. You can write what is the ethnicity, age, what is the gender, what is the current refractive error, and which myopia management option you are planning. Now, what it does is it gives you a nice graph where it can tell you about two things. One, expected myopia progression, and another about what can happen without management and with management. So this becomes a wonderful tool to explain to the patient for counseling. At the same time, it also gives you a gross idea what can be done. So this is one of the first calculators which was designed, and I think there are more and more softwares. LV Prasad Eye Institute have their own myopia calculator, which is also free on their website. Then there are some paid calculators like Pre-MO, and there are multiple calculators. Nowadays, biometers like OBM12 also has a myopia calculator incorporated in that. So more and more machines are having more and more calculators. This is a very similar calculator as similar to Pre-MO. So what this calculator, this is a part of BHVI. What it is doing is it is trying to tell you about pre-myopes. So this is trying to tell you what is the risk of myopia. If you can see, there are three things. One is myopia progression, one is axial elongation, and one is risk of myopia for non-myopic children. So these are, truly speaking, these are pre-myopes who yet don't have myopia. And you have to put certain factors, and it can tell you about whether what is the amount of risk, how much is the risk relative to population with regards to progression of myopia. How does it help you? It helps you in telling you when to follow up the patient, whether you should be aggressive with the patient with regards to treatment, and if the patient is actually showing some axial elongation, you can start the treatment much earlier than what you would otherwise do. So in near future, yes, we do predict that all this work which I have shown you, or the calculators which I have told you that you can use on your own, there will be AI incorporated into that. There will be AI predictors, and all the variables that we right now think about or discuss about. There will be more variables, more design of AI which can predict. This will be, I think, this will be very close in near future. There will be more and more work on tear film biomarkers. Maybe we may have some tests which can tell us by seeing tear film or by doing a biomarker test to know whether this particular patient would progress or not. Right now, when we treat with atropine, one of the basic problems is compliance. So we may have longer active molecules, or we may have some delivery systems which can help us to keep atropine or similar molecules inside the eye for a longer period of time. In another 8 to 10 years, there may be calculators which may be based on genetics, where we may have a genetic mapping, and we may have particular SNPs, single nucleotide polymorphism, to detect whether this particular patient has myopia, will have myopia, or this patient is more susceptible, and there is a gene which is interacting with environment, and based on gene environment, what will happen, whether he will predict whether that particular child would progress or will not progress. So prenatal testing, genetic profiling may come up in future. Right now, we don't have all this, but this could be the future of myopia diagnostics. So thank you so much from my side. I'm sorry if I exceeded the time.
Thank you very much, Dr. Jitendra, for the excellent talk. You can stop sharing and taking us through the whole gamut of diagnostics, myopia diagnostics. I think it's coming up in a long way, especially with something that may be regard to fundus photography also. And that may also come up in the future. We would like to take questions from Dr. Madhavan. Any comments or questions?
Yes. It was a very exotic talk, rather. So it's eye-opener for us all. So, and the future itself looks very amazing for us, because I would like to know what will be the cost effectiveness of all the instrumentations for if a general ophthalmologist wants to set up a myopia practice, one. And number two, nowadays we do a lot of school screening. So what would be the ideal methodology for large scale, giving the opportunity for school children also to get this affordable at an affordable cost effectiveness and high volume? It was amazing.
I think once we have more and more advancement, I think instrument would become cheaper. I don't think they are like Myopia Master is definitely expensive, but OBM 12 is manufactured in Bangalore, I think, and by Remedio. So I think it is not a very, very expensive device. Regarding school screening, I think we will have to stick to
video on Panek.
Oh.
Sorry, sir. Apology.
Okay. Yeah. So I think for school screening, I think we should stick with, mainly in myopia, I think we should stick with cycloplegic refraction. So that is the bottom line, because it is very easy to over predict myopia, because kids have a very strong accommodation. And so if we so the model which we follow is similar to what we learned at Aravind Eye Hospital. We tend to check those children. We bring them to the clinic and check most of them after doing cycloplegic refraction. Regarding the profitability or ROI of the equipments, I think because in India the volumes are going to be very large. And so the ROI will not be very difficult. I think these people who are selling the glasses, like the companies who are into that, may end up bundling the products with ophthalmologists, because this is going to be a very big business.
Yes, sir. Thank you, sir.
Thank you. Dr. Kavita, do you have any questions or any points further to discuss on this?
So, thank you, Dr. Jitendra.
I think we lost her.
Yeah, she's left. Oh, she's there very much.
Yes, Kavita, we lost you.
Oh, I'm so sorry. I got lost. So I want Dr. Jitendra's comments or anybody else in the panel about the scores, the myopia progression assessment scores with which we can choose which patients will, something, so what you showed, or more of cost related. And the other thing is risk related, right? Like parental myopia, environmental factors. So how do we use that into how we look at progression?
So actually, I'll just comment and then we can take comments from other speakers as well.
Yes.
So what we do right now is, I did not talk much about that, mainly because we had a short time and I wanted to cover upon newer things also. And so there are multiple scoring system. One of the very good scoring system is pre-MO scoring system, which we use, and no financial interest, but we use that. There are charts available, and you can. So they have a separate age groups for scoring system. So what they believe is that children between 6 to 9 years would progress at a different rate compared to children between 9 to 11 years and children between 12 to 15 years. So they have different scoring system for different age groups. And then there are cutoffs and the risk factors. They mainly use four things. One is keratometry, axial length, whether the baseline axial length, keratometry, and refraction, the baseline refraction, and whether any of the siblings and parents had myopia or not. So based on that, there is a scoring system which they have created. And if you add upon a risk score of more than 4 is supposed to be significant. That was in the NICER study, the North Ireland Children Evaluation Group. But the study which we did to validate that pre-MO scoring system, we found that in our population group, a score of 5 or more was significant. But then I think you can use it for all your patients, because most of us now have a lot of data. and we can use it retrospectively to see which particular score fits our this thing. It also tells you about the fact that this particular patient may progress and what should be the time duration when you should see the patient back if the patient is pre-myope. So that is regarding one particular scoring system, but there are multiple scoring systems, and you can use any scoring system for your practice.
So I would like summarize, how to look at myopia progression. So there is now myopia is not just a refractive error. We just do a cycloplegic refraction and prescribe glasses and move on. Myopia is no more that. Myopia requires at least baseline cycloplegic refraction, history of myopia in siblings and parents, and axial length measurements and peripheral refraction. So these four, whatever else we do or we don't have, these four are mandatory for myopia as a whole. Like now, I think we can't sit back and say I do only this and I just start on some treatment. So that is not how myopia is treated anymore.
I think the baseline axial length, as you have rightly said, baseline axial length is the key, because it would be impossible for all of us to know whether the progression was indeed axial or not when the patient comes back. So
Exactly.
baseline axial length and keratometry would be the key to differentiate whether it was axial elongation or any problem with curvature myopia.
Thank you.
Thank you, Kavita, for the good points. Should I go start my presentation, sir?
Yes.
DC, sir, you're muted.
I'll introduce you, Sandra. Yeah, Dr. Sandra is.
Yes, ma'am.
Yeah. Oh, no, you're here.
Yeah, go ahead, madam.
Okay,
Go ahead.
medical consultant in the pediatric ophthalmology department of Aravind Hospital, Coimbatore. She's been with us for the past 20 years. She's also reviewer of JAPOS and JPOS and IJO, and recently today as the new research journal of TNOA. She's got 43 publications and 96 citations, and she's won the Best Paper in Pediatric Ophthalmology Strabismus Award in TNOA in 2011 and in AOC in 2015. Presented various papers, and special interest is myopia and low vision, and she does a lot of work with the CVI children. And over to you, Sandra. We are proud to have you with us.
Yes. Dr. Sandra will be talking to us about myopia spectacles, myopia control glasses, which is the talk of the town and talk of the world. Over to you, Dr. Sandra.
Thank you, sir. Are you able to see my slides?
Yes.
Yes. So thank you very much. I'm honored and pleasantly happy to have Kalpana Madam introduce me as my teacher. And I'm going to be talking on myopia control with spectacle lenses. So see, the standard of care for myopia glasses has been single vision glasses. But for many years, there has been attempts to slightly modify the design of these glasses in order to slow the development of myopia. In fact, it goes beyond around 60 years back, because high accommodation is linked, weak accommodation has been linked with progression of myopia. And so there is an increase in the accommodative demand. So we have been trying to reduce the accommodative demand in the previous design of glasses with bifocals and progressive additives. But recently, for the past 7 to 8 years, there has been a whole new generation of glasses which has been designed specifically for the control of myopia. The first of these would be the DIMS glasses, or the defocus incorporated multiple segments, that came out of Hong Kong Polytechnic University, and it was taken over by the Hoya started manufacturing it with the brand name of MyoSmart. That was in 2018, followed by the HALT lenses, or highly aspheric lens-led technology, in 2020, which was predominantly designed by SLR technology and named as Stellest, and they did a lot of studies in China on that. The Zeiss came out with, initially they had a design called MyoVision, which came around 10 years ago, and then they went on to develop the CARE, or the cylindrical annular refractive elements, in 22-23, and that was also out of many studies in China. And there are newer glasses like the diffusion optics technology that came around 22 by side glass visions and many other newer designs as well. The attractive thing about these glasses are that they are non-invasive and they are first-line optical options, similar to what the single vision glasses which the children would wear, but maintains central clear vision and induces a defocus peripherally. The rationale behind the design of all these glasses is peripheral defocus modulation. Means that in the central area, there is a focus in front of the retina, but the periphery, owing to the shape of the retina, it goes behind the light sensitive layer, and that is called as the peripheral hyperopic defocus, and that tends to cause the progression of myopia. So the design of all these glasses tries to inhibit the axial elongation by creating a myopic defocus. So coming to the DIMS lens structure, you have a central clear area of around 9.4 millimeter, surrounded by a honeycomb design, which extends to around 33 millimeters, and that creates overall myopic defocus of plus 3.5. So as you can see in the center part, there is a clear vision, while in the periphery, it is the defocus area, which gives a slight blurred vision, but that architecture helps to control myopia. So there, as I said previously, it has been around for 8 years in the market. So there has been the long-term studies with regard to DIMS, and this particular study talks about the efficacy of wearing DIMS glasses for 8 years continuously compared to various other permutation and combination of DIMS glasses where either start with single vision and progression to DIMS or vice versa. And they found out that the continuous wear of DIMS over 8 years has been very effective in controlling the axial elongation and myopia progression as well. Similarly, there has been studies which combine the DIMS glasses with atropine. This study is with 0.025%, and it's called an aspect study. So here also they found that the combination treatment gives much more control with regard to stability of myopia, axial length and spherical equivalent compared to using the atropine with single vision glasses. So, and also they found that there was absolutely stoppage of axial length growth in around 40% of children, and they achieved emmetropic age-matched axial length growth. And all these combinations, the vision-related quality of life is quite good. They do not affect the quality of life except for the initial adaptation period. So that seems to improve the children's quality of life in the long term. And coming to the, whenever you try to evaluate the efficacy of any treatment modality, what is the benchmark guideline? So this benchmark is given by the US FDA that says that a mean difference between the intervention group of around 0.25 diopters per year can be regarded as clinically significant. That is 0.75 over the course of a 3-year study. So this is the benchmark they used for evaluating the efficacy of various modalities. So this 0.3 millimeters over 3 years, and that corresponds to like 0.1 mm change in axial length corresponds to 0.25 diopters of myopia. So you can remember like that. And basically now all the studies are comparing to the emmetropic progression, because you cannot really stop the growth of the eyeball in a growing child. So we need to compare with the emmetropic progression. And as when we get it as close to the emmetropic progression, then it means our therapy is successful. As you can see in this particular graph, the lower line is how the emmetropic eye growth is from the age of 7 to 12, where the upper line you can see at the age of 7, it is a huge jump in the axial length, like almost 0.6 millimeters, which will translate to maybe even 1 or 1.5 diopters per year. So the objective is to slow the rate of growth. So these are the charts which are given by Orlinda or longitudinal study of myopia and the SCOM studies, which gives the emmetropic growth for various ages compared, and also the myopic growth. And you can use this in your clinics for the model. And also there has been studies with regard to pre-myopia, where they have used the DIMS classes with plano DIMS, and they have found that the spherical equivalent has remained stable over the period of the study, which was 9 months. But how far it is practical, it is difficult to say as of now. Coming to the Zeiss MyoCare design with the care or the technology, here again, the concept is the same. It creates myopic defocus and it forms a caustic focus in front of the retina. It's called as the simultaneous myopic defocus. And here you have like 2 different designs for children younger than 10 years. That's called MyoCare, which is a stronger design. with a central clear zone of around 7 millimeters, and the myocare in older children with a central zone of 9 millimeters. So the myocare gives an add of plus 4.6 overall, and the myocare gives 3.8. And so the range is from -9 to -6 cylinders. And there has been this multi-center trial comparing between fast and slow to moderate progression with the usage of the myocare lenses, found that the risk of fast progression was reduced. And also a couple of studies which shows that it slows the myopic eye growth to come closer to the emmetropic growth. And this is our own study which we presented in ARVO this year, where we found that over a period of 1 year, both the axial length and spherical equivalent seems to be much less with the myocare group as compared to the children wearing single vision lenses. The variability of all of them is quite good, provided the only thing you need to check is the centration and the correct refraction, and counseling the parents that adaptation may take up to 1 week. Most of the times when they come back with non-variability, it is because of a centration issue. Coming to the Halt lenses by SELR, again you have like 11 rings of 1021 contiguous aspherical lenslets, and they create a volume of non-focused light in front of the retina. So Halt, you have studies going in for the past 5 or 6 years, where this study has found that Halt lenses slowed down the myopia progression by 1.75 diopters and over 72 months. And on comparison, there is a study on pre-myopia as well, where they have used the planar Halt lenses in Shanghai, China, over 108 children. And they found that wearing for more than 30 hours per week slows down the actual elongation in high-risk pre-myopic children. And combination with low-dose atropine works with the Halt lenses as well. The newer designs include the side glasses diffusion optic technology based on the image contrast, where you have central 5 millimeter zone surrounded by 0.1 millimeter dots, which reduce the contrast. And they have come with the 0.2 dots as well now, which seems to work better. And there is a new lenses called Lari, which have the both negative and positive types. And the new concept is that the defocus can work whether it is in positive or negative, it doesn't matter. So the exact methodology of how the lenses work is now a little questionable, but it seems to work. So the compliance and follow-up is very important. It's very important that the patient wear the glasses for most of the hours per day, follow up every 6 months, monitor the spherical equivalent refraction, cycloplegic and axial length, and reinforce consistent use for optimal control. The cost effectiveness is one thing we need to look at, because most of them are much more expensive as compared to single vision glasses. But when you look at the risk of long-term complications, then over the years, it may help in cost saving when considering the future eye disease prevention, because anything more than 26 or 26.5 is a risk for high-risk degenerative myopia. So the future directions are that definitely these are safe and effective, with giving around 60 to 70% efficacy, especially with the combination. And but definitely you have to emphasize on increase outdoor time, reduce gadgets and prolong the near work, early intervention, consistent use, AI-based, as Dr. Jitendra also said, AI-based personalized designs and integrated with digital eye tracking for compliance monitoring. Many other things may come up in future also. Thank you.
Go ahead, Dr. Sandra. You can ask about comments.
I think, yeah, I should invite Dr. Meenakshi for the comments on, yes.
And good presentation, Sandra covered all the topics. I just have two questions. Have you tried it in pre-myopia, as shown in some of the studies which I've talked about?
No, madam. As of now, in pre-myopes or especially with the family history or no, madam. As of now, we are not doing any active intervention in pre-myopes here in Coimbatore. We are mainly concentrating on behavioral and environmental modifications. Any other panelists or speakers have tried any active intervention in pre-myopia?
Jitendra?
I think, yeah, I think we did publish a paper in 2022 IGO where we had used atropine in pre-myope children. So these pre-myopes were basically all the children who were already with us, and that is why I was trying to say that, all the children who come to the clinic, we should try to take axial length, because it becomes very easy to talk with the patient, because you have a hardcore data where you can tell that, see, your axial length is actually increasing, regardless that you are still emetrop or something. So atropine, yes, as a drop, it does work. Regarding glasses, the only issue is that I think me and Shruti were discussing. The only issue is that you cannot give glasses to children for not having glasses. So in you cannot tell the patient that you should wear glasses now so that you don't have glasses later. That is hilarious. So you can always give that in children who have astigmatism and don't really have a spherical power. So all those pre-myopes who are astigmatic they can be good candidates for myopia control glasses.
That's a very pertinent point, Dr. Jitendra, because many a time we see that whole thing start with an astigmatism and then progress into compound myopic astigmatism.
Yeah.
All myopes, all astigmatics, we should try to take axial length, as that would be a good idea.
So on that same note, I have now started giving glasses for astigmatic children if they are pre-myopic. The BHVA calculator actually helps us to assess the risk, and the parents also get convinced easily with a Primo calculator or a BHVA calculator. We just have to show them that this is the risk, and especially with parental myopia, you have a risk of going ahead with myopia in the future. So they pretty much have a good uptake. So astigmatic children with astigmatism in pre-myopia, definitely we can.
What is the lowest you will prescribe, Shruti? Lowest
Plano,
is
ma'am. Like Plano with astigmatism.
No, that's what. Plano with astigmatism. What's the lowest? Like 0.75?
Actually, up to 1.5, usually we don't have to give classes. Up 1 or beyond is where we anyway give classes. So I would say probably -1, or wherever the patient actually requires glasses for astigmatism, maybe -1 or above, we can add them with the spectacle control lenses.
Patient improves from 6.9 to 6/6 with -0.75. Should we give glasses to these patients?
Yes.
Yes.
It would definitely help them.
So I think if there's a concrete evidence that the glasses are working, so most of the cases, as Dr. Shruti said, most of the cases are actually able to manage without glasses but if there is a definitive evidence, we should definitely give glasses, because they are managing it, not really having clear vision.
I think they can also be symptomatic. Like sometimes the patients, they may be reading 6/12 and say, I'm completely all right. And then sometimes it's the other way around. They'll be 6/6 parts and they'll be symptomatic. So I think that subjectiveness is also there.
I think probably it will be a good idea to document the axial length in the astigmatism first. And if you document a progressive increase in the axial length, then go for probably a control.
No, absolutely. Absolutely.
Yes,
No.
with progression.
So we are only, the crux is that we are in the business of managing myopia progression, not myopia.
Yeah.
Myopia progression, that is the key, myopia progression.
So we document 6 months and then show them this progression has happened, this loss of hypermetropic reserve has happened, and then they're easy to understand. They feel it's easy.
Yes, we should not give a wrong message, because we see the atropine being misused for astigmatism a lot. So, yes.
Absolutely. Thanks for clarifying that, ma'am.
Yeah, glasses are also being given right, left, and center over the counter. Myopia control glasses.
Yes, yes.
Variable designs also.
Yes.
Dr. Janani, any comments again on this topic?
Thank you, ma'am, for your valuable insights on this. So in our daily practice, many children do come with so much of progression at the age of 15 to 17 years. So because increase in studies, so near works, a lot of stress in near work. So 15 years from 10th standard to 12th standard. So what is your mode of treatment, ma'am? At the age of 15, you start myopia control glasses or atropine.
Yeah, there are two things. So one is a new myope being diagnosed at the age of 15 years, or somebody who is coming regularly for review and still they are continuing to progress beyond the age of 15. So when a new person comes, probably we don't know their previous history, because how long it may happen that they may not progress or they will progress. So it is always better to see, I see at least for 4 months before advising a myopia control strategy when they come newly. because you don't know at what point of time the error has happened. But if they are a regular patient, they have been coming regularly, but even beyond 15, they are continuing to progress in spite of so already we may have started them on some intervention like atropine or myopia control glasses. So if they are on one intervention, then we add another intervention. And if they are already on two, then the question comes on how to taper them. So the good idea will be, see, 15 is not any magic number. You just have to wait for at least 1 year or 2 years of axial length stability before you try to change your or taper or stop your mode of management. That is what we follow. So I think in the interest of time, we can go with the next presentation. Dr. Shruti Nishant. So she will be talking. 1 second. Can you see my presentation?
Yes. We can see.
Okay. 1 second. I think just give me a second.
This is on top. Third,
Yeah,
fourth,
yeah.
next. That arrow mark in the middle.
No, it's hiding behind.
Oh, okay.
Yeah, by my original one. 1 second.
Okay.
Yeah, now you can see. Sorry. Yeah, sorry about the confusion. It's seen now, right?
Yeah.
Okay. So Dr. Shruti, she is the head of strabismology, pediatric ophthalm and neuro-ophthalm, MNI Hospital, Chennai. She has been the joint editor of TNOA Journal, review of TNOA, IGO, BMJ of Open Ophthalm. She's got travel award grant recipient of the International Myopia Conference. She's very active in numerous myopia conferences. I keep seeing her in numerous webinars as well. She holds a patent for developing novel wearable device for measuring the dynamic sunlight exposure, the Lumino sundial. She is currently doing her PhD in myopia. She has won best poster many times in our state and national societies, and numerous awards as well. And she's runner-up PhD student in the clinical research category, and also she has presented posters in RO. So over to you, Dr. Shruti, to be talking on orthokeratology option for control of myopia.
Thank you, ma'am, for the lovely introduction. I think Sandra ma'am and I, we've been going all of these webinars together and all of these conferences also together. So pretty much it's really nice to have someone together like this. So today I'm just going to be talking about orthokeratology and other contact lenses option in children. So primarily, before we kind of move into the topic, I think there are two big white elephants, like the questions we need to address before we go on. The first question is, do we need contact lens in myopia management as a part of our armamentarium? The answer is a big yes, because we need it for 4 areas, primarily for children who have extremely high refractive errors, which may not fall into the category of spectacle lenses. Second, children who are active into sports and children who do performance arts and all of them who would not prefer to wear glasses. The third is accommodative lag specifically is a contact lens indication, and of course children who are poor responder to other modalities. Now, the second big question that needs to be answered are these contact lenses really safe, and is it really worth going in for all these? Again, the answer is now yes, because nowadays the lenses are really much better than the previous ones. So Cheng et al. In 2020 reviewed 6 randomized control trials involving 581 myopic children, and he reported, in fact, no adverse events. However, another study by Hiroka et al. In 2024, which is more recent, found that the risk of microbial keratitis was 5 cases per 10,000 patient years versus 13 cases, which was there much earlier. So this is about almost 60% reduction in the number of keratitis cases that have been reported. And that's probably because of the better quality of lenses that are coming up. And almost these rates kind of match the adult rates of microbial keratitis in contact lenses wear. So having said that, now let's move on to addressing the topic itself. So myopia in itself, when it comes to contact lenses, we look at myopia correction and then control. It's very important to understand that myopia, soft contact lenses, the regular lenses that we wear, provide myopia correction. However, they do not provide myopia control. Now, what are the lenses that provide control? So these are the three, the dual focus or the center distance multifocal. Now these lenses have the center will be focused for distance, whereas the rings are for plus power. And the second is the extended depth of focus, and the third is the orthokeratology, which we'll be discussing. Now, when we look at these lenses, the dual focus contact lenses or the MySight or all these are not available here with us. They work on the principle of simultaneous defocus. They have two specific rings in their lenses, which are focused at different areas, and they provide correction for the peripheral hyperopic defocus while the center gives the visual clarity. The second one, which is now available with us, is the extended depth of focus lenses. And these lenses are very similar to the EDOF IOLs that we see. And you can see that these have these kind of rings that provide a kind of depth of focus, which start from distance and then go on to plus reduce. So the center will have the highest minus, and then as it moves to the periphery, there'll be reduced minus, which kind of gives the similar effect of a myopic spectacle correction lenses. And this is just to iterate like one of the case examples which I had, where a specific use case of EDOF contact lenses was there. This was a 5-year-old male whose both parents were high myopes, and the child, of course, had high myopia, -16 with 3.25 SIL and -17 with 2.25 SIL. Child had esotropia and was, because of the first visit, child was put on single vision glasses. And when there was progression, we added the 0.01% atropine once a day. This went on for 1 year, and probably at the end of 1 year, we continued to see a progression. You can see this minus 18.5. It continued to progress, which is quite rare for such a high myopia, but it just happens sometimes, and then there was progression. So we shifted the child to a soft contact lenses, and we put them on the maximum, which was -12. And the residual astigmatism and the spherical was put on single vision glasses. And then we changed the atropine to twice a day for the next 1.5 years. And then you can see this kind of progression still continued to happen. And so at this point, we had two options. And option one was to kind of give the same soft contact lenses with the DIMS glasses on residual power, and to continue the low-dose atropine on BD, so that there's some form of a combination therapy. However, what we found out interestingly in this patient was there was a lag of accommodation with the receding near point of accommodation. So when you have an accommodative component into this whole picture, then these kind of contact lenses really help. So then we shifted the kid into extended depth of focus with single vision glasses for the residual, because we wanted to test this monotherapy. And surprisingly, what we found was the child started reading better, as well as in fact, even the squint kind of, the esotropia kind of reduced. And then this child continues to be on these EDOF lenses, and somehow the progression seems to have stabilized for this child with better vision. So that was one use case of the EDOF lenses. I don't give a lot of them around, but sometimes you just have to use them. So now we move on to the interesting thing, which is the orthokeratology. Now, this is a name that we keep hearing through our chapters, through our books, and so on. It's not something new. It's just the same old bean, but in a new avatar, that what I would say, because the newer lenses seem to be much better compliant to the cornea. So the whole principle behind this is that, the same concept of applanation, wherein these lenses in myopia, because the eyeball is longer, the rays are focused ahead of the retina. And then what these lenses do is they applanate the cornea and they press it, thereby putting the focus back onto the retina. And what happens during the next day is that the applanation kind of takes some time to come back, so that the point of focus continues to remain on the retina for a period of one or 1.5 days. So that's the whole concept. So where it started was through a PMMA lens, which was way back in the 1960s, and it was called the orthofocus lens, introduced by Dr. Jessen. And these designs were, the diameter was less, and they kept decentering up and down. And of course, because this was PMMA, it didn't allow any oxygen permeability. So it was again in 1972, or maybe almost 10 years later, that Fontana introduced this so-called reverse geometry lens. And then he practically applied it using the Context Labs, and Nick Stoyan was the person who patented it finally, with these 3 distinct zones that I'll be talking about. Now, modern orthokeratology have these kind of 4 zones. The first is the central zone, which is called the base optic zone radius, which is where the actual vision gets and the applanation happens. The second is the reverse curve, or the so-called reverse geometry, where the rays happens and the tear fluid there collects, forming a hyperopic correction. And the third is the alignment zone, which actually provides the fitting for the lens on the cornea. And the fourth is the peripheral curve, which is a slight edge lift, as you can see here again. This provides the fluid to flow in freely between the layers, and also allows for a little oxygen permeability. So you can see the second and the fourth are where the actual tear film forms a reservoir. Now, how it basically works is because of the central positive push force, there is an applanation which actually creates the myopia correction. And this negative pull force that happens in the mid-periphery, this is the one that actually controls the myopia progression. So the center gives the correction while the mid-periphery creates the control. So this is how it works. So the myopia correction works by the central applanation, which creates a migration of the lens epithelial cells to the mid-periphery, whereas the myopia progression control happens again by the concept of peripheral hyperopic defocus, wherein the mid-peripheral tear reservoir acts as a plus lens, and thereby it pulls back the rays from the periphery to the inner aspect of the retina, very similar to how a DIMS or a Stellest or a MyoCare lens would work. Now, having said that, how good is the effectiveness? They say its effectiveness is as good as the spectacle lenses. And practically in my experience, I find it to be quite good as well, with a small reversal in the initial phases followed by a good stability later on. There are RCTs that talk about orthokeratology where, it has a very good result and good control as well. Now, why are the newer Ortho-K lenses really good? One is because of the high oxygen transmissibility. The earlier Ortho-K lenses did not have much of a decay, but that is a diffusion coefficient. But now the newer ones specifically have a good decay value, and this decay by T ratio, which is nothing but the diffusion coefficient divided by the thickness of the cornea. So this was way back in 1984 by Dr. O'Neill. He found out that a minimum of 75 decay by T ratio is required to prevent corneal edema when the eyelid is closed. And now the newer lenses seem to have a little higher than that. So that's why the safety has come about. The second is the structure of the lenses. The earlier lenses had MMA and silicone put together in a joint manner, whereas the newer ones tend to have the silicone in the center embedded inside a MMA molecule, which gives a little more strength. And because the strength is more, the breakability is also lesser. And that is again being tested by an iron ball, which is dropped. And you can see the older Ortho-K lenses can break, whereas the newer ones can really take impact quite well. And that's the reason why the modern orthokeratology lenses are coming back with a big bang. And also the newer lenses are designed specifically for Asian eyes, and because our Asian eyes tend to be relatively flatter than those of the Western people. Now, putting all of this together, let's go into the practical aspects. The equipments that are required are an autorefractor, a corneal topographer, a slit lamp, and a trial set lens, pretty much the basic things that we already have in our clinic. An ideal candidate is someone who is less than -6 spherical or -2 cylinder to start off with. What is important to understand here is the concept of play off between keratometry and correction. Now consider a patient who has -2 of refractive error with an average keratometry of 43 diopters. Now what Ortho-K is going to basically try to do is push this refractive error correction onto the cornea. So if it's going to be corrected, you want an ideal refractive error of 0 at the end of post Ortho-K, whereas the same -2 would be applanated onto the cornea, leaving a residual of 41 diopters instead of the 43. So it is important to understand how much you can applanate the cornea, not how high the power is. So the power has to be matched to the keratometry, and that's important to understand. So the concept is higher the power correction, you can do it provided your cornea is steep enough to take it. How steep? You should imagine that after minusing for all the power correction, you should still have minimum of 39 diopters of keratometry left. Now let's do a small example of a case. This was a 12-year-old female with -4.5 diopters and 0.5 cylinder. Average K was 45 diopters and normal topography. This is the topography, and you can see there are 3 things required to fit an Ortho-K: a fitting curve, a target power, and a dia. The dia is usually fixed. Now, how do you calculate the fitting curve? It's very simple. You need to take the fit K or the average K. The average K on the keratometry actually is the fitting curve itself. You can just use that from the trial set as a first lens to try. Secondly, you need to determine the target power. Now, this is a very simple calculation. You need to take the sphere, and that you have to keep it here. And then you need to take the flat K minus fit K. So the flat K is the flatter K, which is the horizontal one, 44.25, minus the average K, which is the 45. And that gives you a 0.75, which you add it, and it gives you minus 5.25. And that gives you the target power. So this is what you essentially need to start your trial. So you can start your trial with any of the powers, -4, -3, whatever you have in your trial set, but then you'll have to adjust to a target power of this through over refraction. So how do you fit the eye? You have to fit it using, like you just put paraffin, put it on the eye and then allow them to blink for a few minutes and then stain the eye. And you need to see these nice this kind of a pattern. And remember, you do not want a steep fit or a really flat fit. And this is what you would ideally aim to have. Now, after the lens is fit and you're satisfied with it, the patient has to sleep for 1 hour with the Ortho-K lens. And after waking up, again, you need to look for the fit before you go for the over-refraction. Remember, in Ortho-K, the fit is more important than the over-refraction. So always be satisfied with the fit. And after the fit is still satisfactory, you stain them and you see that this nice ring is formed, this bullseye pattern is formed, then you go ahead and do the over-refraction. So for the over-refraction, ideally, you want to result in a minus 5.25 plus or minus 0.25. If you have something like that, then you can dispense it. Remember, after you dispense it, you have to ensure these 3 instructions are given. You have to place the lens in the eye 15 to 20 minutes before sleep, minimum sleep for 7 to 8 hours, and remove within half an hour of getting up. So after management, you need to ask them to come back after 1 week, 1 month, 3 months, 6 months, and annual. You need to be able to see a ring like this that's really clear. This is pre and post. Within this radius of the ring, you need to see that the difference between these 4 measurements should be within 2 diopters in order to prevent astigmatism. That is very important. So that's part of the thing you look for. Always look for the cornea to look for any aberrations or so on. Measure the refraction, axial length, and the topography once again. So these are the after management things that you look for. Of course, there are some troubleshooting points. Due to lack of time, I'm going to skip that. There are 2 lessons which I learned the hard way with over 2 cases which I never repeated again, and that's something I would like to share with you. Those are my mistakes. I hope it's never done because this was part of my learning curve. This is lesson number 1. This was 11-year-old girl. This is both these cases are from my earliest times of fitting. High myop, first mistake. Second was a keratometry of 42.9. Again, you can see that when you minus this, it comes much lesser than 39 diopters. So this child had a little bit of central aberration. You can see that, which was identified in the first week post fitting, and then we immediately stopped and discontinued the lens. So this is lesson number 1. You should always match your myopia to the keratometry. The second lesson again was a 10-year-old girl, was minus 3.253, keratometry 44. If you look at the threshold, it's still good. 44 minus 3 is only 41. So still it's a good, but still why did this patient have a little bit of aberration? Because this child had a limbus to limbus astigmatism, and that is an absolute contraindication to fit Ortho-K. You should not choose limbus to limbus astigmatism because the fits are very bad. You should always choose patients with central astigmatism. So these are the 2 lessons which I had learned early on in my practice, which I've never repeated again. But I'm happy to say it's nothing to worry about it. Further, all the lenses what we have fitted have a really good effect. Going in the future, there are 2 things which are coming up. One is the MedMount topographer, which is a customized topographer, especially for Ortho-K fittings, which can give you really customized fittings. And the second are these so-called over-the-counter Ortho-K lenses, which do not require any form of fitting. You just have to take the refraction and give it to the person, and they will just give it to you ready-made. So these are all coming up in the future. So to conclude, EDOF lenses has a limited role only with children with accommodative lag. Ortho-K is an effective and efficient strategy. Always choose a patient whose parents are understanding, sphere less than 6 diopters, astigmatism less than 2 diopters, no limbus to limbus astigmatism or any ocular surface disease, and calculate the post-correction keratometry not less than 39 diopters. So all of this, if you follow, you will enjoy and see the patient enjoying the Ortho-K wow effect. And I think you can take it up in your practice on a regular basis. Thank you so much for your time. And I'm sorry if I have exceeded my time limit.
Thank you so much, Shruti. It's always a pleasure to hear you talking about Ortho-K lenses. And I think it's more of a hit among the optometry groups. We always hear them talking a lot about Ortho-K. I think ophthalmologists, we can also start to introduce. In the interest of time, shall we proceed with the next presentation and take the questions together at the end? So I would like to introduce the next speaker, my colleague, Dr. Amrita Sindhu. Are you able to see the
Yes, you can go to slideshow.
Yes. So Dr. Amrita Sindhu has been with us since 2015 in pediatric clinic as a consultant. And she's also a certified NABH accessor, and she's been very active in that front. And it's a pleasure working with her. She is very nice to be as a colleague. And over to you, Dr. Amrita, for your presentation on myopia control drops.
Just a minute, I have a bit of difficulty here sharing.
In the meantime, would you like to take any questions by the time she starts her presentation? Any questions on the ortho-K lenses, Dr. Kavita?
Yeah, sure. So see, I don't know, in Shankar Netralaya for myopia control, we still have very limited patient profile. Patients are not really, choosing this as a easy option. It's really difficult to kind of sell it. That is one thing. So how do you convince your patients? That is one question. Second is there any studies, or I mean, I'm not aware of anything combination with any other modality like atropine with ortho-K lenses?
Yes, ma'am. First question is, it is tough. So even I have a very small select group of patients on orthokeratology. It is challenging to convince them. However, the thing is, I offer it to all patients. That is the thing. Every patient that walks in, I offer ortho-K, and then there is a very small percentage of patients who take it up. That's how it is. The second thing is with regards to what was the question, ma'am?
Combination with atropine.
Combination, yeah, there are several studies that talk about ortho-K with atropine, and they are have a very good synergistic effect. And I mean, I'm sorry, I cannot quote them right now, but there is literature available for combination therapy.
Yeah.
And
thank you. Yeah. Thank you. I think Dr. Amrita has started screen sharing. You can proceed with the presentation, Amrita.
Yes, ma'am. Thank you, ma'am. Thank you for that kind introduction. So I'll be talking about the pharmacological management of myopia. So as we all know, the only currently available drug for commercial use for myopia treatment is the low-dose atropine. This is one of the effective and economical way of management of controlling the myopia progression when compared to other modalities. Mechanism of action, still it is not clear in spite of using it for quite some time since till now. One thing is clear, it doesn't act via the accommodative pathway. It has been largely disproved, but it is known to act via the muscarinic receptors which are present in the choroid, sclera and the retina. So what exactly happens is, whenever there is a myopic stimulus happening, there is thinning, there is reduced blood flow and reduced nutrient supply to the choroid and the sclera. This causes scleral remodeling because of the extracellular matrix remodeling. This causes thinning of the sclera and stretching of the choroid, leading to axial myopia. So atropine is known to act at this state, where it can remodel the extracellular matrix present in the sclera and choroid, preventing scleral thinning and causing thickening of the choroid. That is how the atropine, low-dose atropine works. So there are a lot of evidence which proves the efficacy and the usage of low-dose atropine. There are some anecdotal evidence which are present, the usage of atropine in myopia in 19th century, but the real evidence started with two landmark studies, that is the ATOM study and the LAMP study, which started way back in 1998, and it is still going on, both ATOM and the LAMP study, in a phased manner. So what we know in ATOM 1, I want to explain. ATOM 1 just said that the atropine 1% is effective in preventing the myopia progression. So in ATOM 2, which is a phase study, they studied the different strengths of atropine drops, that is 0.5%, 0.1 and 0.01. And we noticed a dose-dependent reduction in the myopia. And also ATOM 2 studied the washout phase, where they actually studied the rebound effect, and it is seen that higher the strength of atropine, higher was the rebound effect. So that is about ATOM 2. And ATOM 3, it is the study of low-dose atropine in preventing onset and progression of myopia in high-risk children. So about the LAMP study in phase 1, it compared the effectiveness of 0.05, 0.25 and 0.01% atropine, and they found out that 0.05% atropine is the most effective in controlling the spherical equivalent progression and axial length elongation. In LAMP 2, it was again the same usage was continued for 2 years, and over the 2 years, there was a cumulative effect, and 0.05% outperformed with the double the effect of 0.01. That was in phase 2. And phase 3, actually they studied the effect of cessation as compared to that of the continued treatment, and they found that rebound was more with 0.05% and was almost nil or very minimal in 0.01 and 0.025%. So, and LAMP phase 4 study actually studies the effect of 0.05 atropine in preventing the onset of myopia, that is between 4 to 12 years of age. And it also studies about the 5 years effective control of 0.05% atropine. So practically in India, we currently have only 2 doses available, that is atropine 0.01, which is commonly used, and of late we have also got 0.05 commercially available. So with this in the background, we have to actually think of what is the best practice we can do, which keeps evolving every day. So when to start atropine? Whenever there is a documented myopia progression of more than 0.5 diopters per year, that is an indication for starting any myopia intervention for that matter. So you can start initiating the therapy in the first visit itself when there is a high risk case. We can consider a child to be high risk when the onset of myopia is at a very young age, or when there is a family, when there is a parental myopia or a sibling having myopia, or whenever you see a higher spherical equivalent at the baseline, or whenever there is a increased environmental risk factors. These are all considered as the high risk children. So some of the contraindications for LDA are any congenital myopias associated with systemic conditions like Down syndrome, congenital heart disease, cerebral palsy, or children on antidepressants. So once you start and what to start. So now we have 2 strengths available. Earlier we used to use only 0.01% in almost all, but now it is proven through all the evidence-based studies that is 0.05% is ideal for younger age group. That is 4 to 12 years of age. You can consider using 0.05% because these younger age tend to progress for a longer time, and their tendency for the axial length elongation is more as compared to the older children. But if the child presents at more than 12 years of age, you can consider using 0.01%. So if the younger children whom you have already started on 0.01% is progressing, then the other option will be you can make it into a twice daily dosage as well. So this is how you decide on the drug which you have to start on. And as many of the previous speakers spoke, 0.01 can be used as a combination therapy, which gives an enhanced benefit when you use it with orthokeratology or DIMS classes. So once you started the child on the drug, you follow them 6 monthly. So every visit you document the axial length, do a cycloplegic refraction. If you're starting on a higher strength like 0.05, it's better to first see the child at 1 to 2 weeks after starting the drugs, because few of these kids show a slight pupillary dilatation which can cause accommodation problem and glare. So safety, we all know that LDA is quite safe and very less side effects in these kids. Few of the kids might develop some amount of allergy. Pupillary dilatation, reduced near vision, and accommodation loss is more with 0.05%. And glare is also a common complaint. So we have one study, which is an ATLAS study, which came out in 2024, which is nothing but the ATOM study participants were followed up over 20 years and 10 years of washout period. And they showed that there is not much of long-term effects like cataract or myopic macular degeneration or glaucoma because of the use of low-dose atropine. Efficacy, as the previous study says, there is a dose-dependent effect on axial length as well as the spherical equivalent, and also it has a cumulative effect. The more the duration you use, it has a cumulative effect, the second year being more effective than that of the first year. So as you follow up, you might come across certain children who are not actually responding or are still progressing. You call them as non-responders when there is a 0.5 diopters progression after you continue the treatment for 1 year. And you can call them as rapid progressors if there is a 1 diopter progression per year. In these cases, you have to go for some additional therapies. One is you can increase the frequency into twice daily dosage, or you can increase the strength of the LDA, or you can go for a combination therapy. So regarding when to stop, there are a lot of discussions happening over this topic. The ideal way is to continue the drug up till 15 years of age. So the earlier thought of stopping it after 3 years or 2 years of usage is not really ideal, especially when you start it at a very younger age. So better to continue the LDA for up to 15 years of age, or if there is a older child, if you document a non-progression for up to 2 years, that is when you decide on stopping of the LDA. But when you're planning to stop the drug, don't stop the drug abruptly. You have to taper it. Is either you can switch to a lower dose and then taper, or you can make it into alternate days for the next 6 months, and then you can stop the drug. But once you stop, you have to monitor the patients for any rebound effect. So when you call it as rebound effect, when there is an accelerated progression after cessation of treatment. In these cases, you have to restart on the drug or go for an alternate therapy. So drawback of this LDA is the compliance. Many of the studies, even Dr. Jetani sir's article shows that the non-compliance rate is almost 15 to 25%, and also the rebound effect when it is stopped abruptly. So it is very important to educate the patient regarding the importance of compliance and proper follow-up. So can we delay the onset of myopia? Yes, LDA has a role in delaying the onset of myopia in pre-myopes. We call the patient as pre-myope when they have a very low hyperopic reserve, that is less than 0.75 diopters to minus 0.5 diopters with risk factors. In these children, we can actually think of starting LDA because many of the studies have proven that 0.05% is effective in delaying the onset of myopia. We have to identify that it doesn't prevent the onset of myopia, but we can just delay the onset. So there are a lot of other drugs which are being tested, especially in animal models. A few of the drugs of importance are pyrazipine, which is a selective muscarinic receptor, which can be used as a gel formulation twice daily, and also tropicamide and methylxanthine, which is an oral preparation. It is under a pilot study, and it is known to change the scleral ultrastructure and eye growth rates in animal models. So conclude my study, LDA is the most commonly practiced myopia control measure. It is safe, effective, and economical way of treatment. It can be used as single therapy or can be combined with other myopia modalities. Careful selection and proper follow-up plays a very important role. Educating about the need for compliance at every point of time, even before starting of the drug and also during the follow-up, is very important. And I want to stress upon one more point, that is LD has no role in pure myopic astigmatism. Thank you.
Thank you very much, Dr. Amrita. Excellent talk and very clear explanation on one of the most cost-effective managements for myopia control and most widely used also. So, Dr. Madhavan, would you like to start the discussion?
I just, at the onset, I would like to thank all the speakers for the wonderful in-depth talk about the myopic latest treatment is myopia and how to prevent progression. And I'm sure the members of our association who have tuned in today would have been greatly benefited from these talks. And it would also sort of, many people have a mental block about starting these type of treatment regimen. And I'm sure these talks will help us in going a long way in breaking the ice, so to say. So usually we start the atropine, low dose atropine, the age of 6 to 12. And as Madam said, we in 3 years' time, when it stabilizes, if we stop at the age of 15. But again, if it shows signs of progression at the age of 17 or 18, can we restart the same treatment regimen?
Amrita?
Sorry, ma'am, I have difficulty in doing the stop share.
Yeah.
No, sir's question.
It's in the center of the.
Sorry, I actually I didn't listen to it because I was
Trying to stop share.
I was trying to stop share. Can you repeat it, sir?
Yeah, I just wanted to know, once we feel that the myopia has sort of stabilized, say at the age of
Okay.
14 or 15,
Okay.
and so as 2 or 3 years later, when the patient comes back, child comes back again, shows signs of progression further, can we
Okay.
restart the same treatment regimen in low dose atropine again?
Is that after stopping the atropine?
Atropine.
If they,
that's right. That's right.
yeah, probably we can think of starting on a higher dosage because they have, it can be a physiological way of again developing a myopia, or maybe we can go for an alternative therapy.
Alternative combination.
Yeah, that would be a better option because it can be because of a rebound effect also. Sana ma'am, you have anything to say about that?
Yeah, I think mostly it would have been because prematurely they would have stopped the atropine. So that's why we recommend continuing the atropine for at least 15 years of age or documenting 2 years of axial length stability, sir. So, yeah, thank you. And Janani, any question? Any further questions you have
So
regarding?
most of us, that was a very useful talk, Dr. Amrita. Congratulations. So
Thank
I would like to ask, many of us have started already on 0.05%. So does anyone have experience about any side effects, intolerance, headache, or any photophobia? Was it an indication to stop 0.05%?
Yeah, actually, I can take that because we've been very recently starting to use 0.05, and we had a couple of patients who came back within 1 week saying blurred near vision issues. Not sure whether one possibility is maybe they are putting more than one drop because the pupil size seems to be a little larger than what it is with the 0.01. Especially when they combine with the defocus glasses, they seems to have little difficulty then. So but that doesn't mean that we should not be used. We have to just explain the parent and like call them within a week, find out just a phone call, find out how they are doing with the drops. And if there is any difficulty, please, we can review the case. Dr.
I had
Jitendra?
one.
Yeah.
I had one parent's complaint that the child, 2 children on LDA, she complained that they had sleep issues, which I kind of could not, attribute it to that atropine, but she was very insistent that the children had disturbed sleep and they were not able to fall asleep soon. So any similar experience, I kind of dismissed it. I mean, reassured the parents, and told them if they're very concerned, they can stop and switch to glasses. But it was kind of nagging with me, but I couldn't find anything like that which is relevant, any side effects like that. But only one parent insisted that 2 of her children both had that.
Something like atropine toxicity, you're saying?
Correct.
Not sure, ma'am. She said that the sleep got a little disturbed. She said ever since we started atropine, the kids are not falling asleep as before and did not have a good sleep, which
Possible. Maybe they are very sensitive. Their absorption is higher, something maybe.
I told them to use it half an hour before going to bed, but I kind of told them to stop if they are not comfortable and switch them to glasses.
We have started 0.05 recently, only few months back, but I also had one patient which had a larger pupil and complaining, so stopped. 0.05%, better tell them to come after 1 week or whatever. If they have any real difficulty, to contact us. Unlike 0.01, which doesn't seem to cause.
Dr. Sujata Mohan, ma'am, would you like to give the final comments and thoughts on this? Ma'am, you're muted, ma'am.
So it was a very interesting webinar. I really learned a lot. And more interestingly, I was very interested in contact lenses, what Shruti spoke, because that was always my field of interest. And I always had a laid back attitude that I didn't want to give contact lenses to young children, chance of infection and hypoxia and all that. But I think she has motivated me to start using orthokeratology lenses. And it's also nice to learn there are so many different glasses, different types of glasses. I always used to wonder which is the best glass. I think, as I'm not a pediatric ophthalmologist, so I think I'm sure most of you know how to manage this. I think this has been a really wonderful webinar on how to manage myopia and how to prevent further worsening of the myopia. It's really wonderful. And recently, in one of our retinal webinars, I also had the opportunity to see that they're using something like a scleral buckle to reduce the pathological myopia. And that one of the doctors from Georgia, he spoke on it, and vision improved from 3/60 to 6/18. So much is coming up, and I always say, there's so little we know, and there's so much out in the world to learn from. And this was extremely useful webinar. I'm sure other listeners also would agree with that. And thank you once again for giving us the opportunity to be part of it.
Thank you, ma'am. Dr. Kalpana, ma'am, would you like to give your final comments as well?
Yeah, Sandra, thank you. It was really nice, to hear from all of you, and Dr. Chaitani talking about the diagnostics and the importance of pre-myopia and checking the axial length, and and that, and also the drug management, the atropine usage, and the orthokeratology, because we also, I and Sandra have been discussing on starting orthokeratology. So, but then the only point is, will the patients be comfortable? But now, I think with Sruchi's experience, I think probably we should also look into it, because prevention is better than cure. So I think we should always look at ways where we can prevent. And recently I had a question from one of the parents that, what about orthokeratology? Normally, we're surprised when parents ask, and also a child above 15 years of age, whether to continue atropine eye drops. So this was really informative to me as well. And thank you all, Amrita, and it was an excellent talk on the drug management. So thank you once again, and thank you, ma'am, for giving us opportunity to be part of the TNOA. Thank you very much. And thank you, DC sir, for putting it together.
Thank you so much, ma'am. Thank you so much. So, Sandra, can we wind up? Yeah.
Yes, sir.
Once again, I thank our president and vice president of TNOA for being here, madam. And on behalf of Aravind Coimbatore, thank you all, the faculty members, and all those who have been watching on the YouTube, and many more who will be watching it later. I'm sure it will be an eye opener. Thank you so much, and good night to all of you.
Good night.
Thank you, sir.
Good
Thank you
night.
so much.
Thank you, ma'am.
Manju,
ma'am.
you can stop.
Thank you.
You can stop YouTube, Manju.
One second, doctor.
Thank you, Manju.
Thank you, doctor. Thank you.